time that I'm in Egypt, and I usually sort of regard the invitation by people from Egypt as an honor, and I try to make sure that I'm here. One of really most important memory that I have from Egypt is when we brought our annual multidisciplinary symposium on breast disease, which this year actually we are celebrating its 20th year anniversary of this symposium. We brought it to Cairo, and we had Common Foundation with us also that they would, sort of pretty much promote the international advocacy concept. And we were able to get the general GE company to provide illuminating the pyramids pink. And during our symposium, the pyramids were pink, and it really got international attention and got to CNN. And I really took a lot of pride in the fact that we were able to really bring something to this symposium to a place like Cairo that internationally recognized for its really commitment to knowledge and science. And as I indicated, it's also a pleasure to be here. So you can invite me anytime. Just give me 6 months and I will arrange it and it will come. Today what I'm going to do, I'm going to be talking about, let's see, how do I do this? Why does it move? Excuse me, how do I make it move? So my plan today is to summarize the current use of breast cytopathology in clinical practice and to provide an overview of the similarities and differences between fine needle aspiration biopsy and core needle biopsy. I want to start with making a statement that really cytopathology is the story of integration of morphology and biomarker studies that together they can really be very useful in clinical practice as well as the breast cancer research. And along the line of that, to give you an idea of really contribution of cytopathology in pathology is excessive, and in many areas in experienced hand, cytopathology can really get to that status of providing the same contribution as surgical pathology. And these are the listing of the contribution. Establish a diagnosis, classify a neoplasm, differentiate between the secondary versus the primary tumor, assess the status of residual tumor in lumpectomy margins, detect the presence of tumor metastasis in sentinel lymph node, and assess the status of adequacy of a specimen in core needle biopsy. And the way that this happens is really use the cytologic samples and material very similar, as I indicated, in surgical pathology and core needle biopsy, to provide diagnosis, predict the response to therapy, predict the risk of subsequent development of breast cancer, and provide tissue sampling for breast cancer research and genetic testing or profiling. The procedures that provide the ability for us to recruit tissue samples and cellular material to use for diagnostic and prognostic information are fine needle aspiration biopsy, imprint cytology, nipple fluid cytology, and of course ductal lavage in a research setting. But today I'm going to just practically focus my talk on fine needle aspiration biopsy. Fine needle aspiration biopsy as a minimally invasive procedure is used effectively to eliminate the need for open biopsy in benign breast disease and to provide a non-surgical means to diagnose breast cancer. And when we really look at fine needle aspiration biopsy versus core needle biopsy, in palpable breast lesions, fine needle aspiration biopsy is a very effective sampling procedure because of its ability. The small, bore of the needle biopsy has the capability for us to really sample the lesion a little bit more effectively because we can move the needle within the lesion, versus core needle biopsy that can move a targeted lesion and really end up to not really have sufficient amount of material to diagnose. Fine needle aspiration biopsy is deviation from surgical pathology. We as surgical pathologists are used to see the entire lesion and then take multiple sections and see what it is. Now, with fine needle aspiration biopsy, we are claiming that we have a few classes of cells, and through that, we're trying to make a definitive diagnosis. So fine needle aspiration biopsy and this practice requires a little bit more imagination, courage perhaps, and a true understanding of what is really our capability to try to use this for enhancing our ability to provide diagnostic and prognostic information in majority of the cases, particularly palpable breast lesions. And to give you an analogy that the controversy surrounding fine needle aspiration biopsy is very simple. Fine needle aspiration biopsy is really trying to look through a keyhole and try to see the entire room. Therefore, it is very difficult when we have an orange-sized lesion in our hand versus a few cells that we are trying to make a diagnosis. The advantages of fine needle aspiration biopsy are numerous, and one of the most important components of that is providing a diagnosis when surgical biopsy is not possible. And we still, in our institution at Florida, we have patients like this that they present in our emergency room. And we go there and with fine needle aspiration biopsy, we establish a diagnosis and pretty much stage the patient so that the patient can be admitted for further therapy. And of course, high acceptability. There are many women that the fear of the scar on their breasts, for whatever reason, have shied away from either core or surgical biopsy in the past. And therefore, cancer stays there, and the cancer naturally metastasizes before they come for therapy. I've had multiple patients that they were moderate or a high-level situation that if we had not offered the fine needle aspiration biopsy as initial diagnostic procedure, the patient would have not been diagnosed with breast cancer as early as we had been able to do it. And of course, cost effectiveness. And in the era where cost has become a major problem in all over the world, we have to exercise a process upon which the cost of providing care would be diminished. And of course, that becomes a little more difficult in countries of limited resources and among medically underserved population. When we look at the progression in breast cancer over several years, mortality from breast cancer has decreased about 1 to 2% per year since 1990s in resource-rich countries. However, mortality from breast cancer continues to increase in countries of limited resources and among medically underserved population. And this is a very alarming process, and it's really an almost injustice because we have the ability to try to make the progress that has been made available to all women across the world, and we really are not able to do that. These are examples of neglected breast cancer cases, and I'm presenting that to you. This is not only in countries of limited resources. At University of Florida, in Jacksonville, I work in an indigent care facility, a community-based, poor area of the city. These are the cases that we still see, and anytime that we see something like this, I think this is a slap in our face that we have had no ability to try to reduce occurrence of this kind of process. And you can see that in that setting, having a mechanism that with minimal really effort would be able to provide diagnosis is very, very important. What are the barriers in providing high-quality breast care across the world? Diversity in patient population with different genetic backgrounds, social values, religious beliefs, lifestyles, and culture, and differences in economic status and healthcare priorities. In countries where the still water and infectious disease are main component of that, it's very difficult to get the leadership in healthcare to really pay attention to breast cancer. So, in the era where we are sort of practicing, I have always, all my professional life, I had tried to see whether there is a possibility that with all of the component and hysteria associated with core needle biopsy and surgical excision and image-detected biopsy and ultrasound-guided fine needle, to promote the value of fine needle aspiration biopsy and cytology as the most cost-effective procedure. It really doesn't take much of anything. It's just a small needle, and you can even train your healthcare providers, a nurse, a social worker, somebody to be able to really provide this sampling so that the patients with fibroadenomas don't lose their breast on that in certain countries of the world that we still don't have the way to diagnose breast cancer. And the suggestions that has to come in an international era is the fact that there has to be encouragement of international collaboration among individuals that are interested in breast health care and they're interested in women across the world. And that includes assistance in training, offering access to pathology services, and of course telepathology is an area that can be really implemented with much less difficulty as has been anticipated, and there are centers that they do that with having a telepathology, you can do the sampling, prepare the slides, and send it to the centers that they are interested and capable to try to provide that diagnosis. And these are examples of cases that you can see that you can very easily diagnose breast cancer. Now, in practice of breast fine needle aspiration biopsy, the most important thing, thank you. The most important thing that we need to understand in practice of breast cytopathology is that atypia does not always signify malignancy in breast fine needle aspiration biopsy, and lack of atypia does not exclude malignancy. And diagnosis of breast fine needle should be based on the interpretation of defined cytomorphology in the context of the other available clinical findings. Give you an example. This is the case that when you look at it, individual cells and these clusters, they're highly atypical. They're large, they have nucleoli, and they have lost the polarity, they're all over. But when you look at it, the background of all these acute inflammatory infiltrate would give us the indication that these cells are living in an environment that is hostile, and therefore they're reacting to that. So this does not mean that we have to call it atypia. The term of atypia in pathology should be really abandoned. Atypia is a reflection of our ignorance to the case and our inability to stand for morphology that is solid in trying to make a diagnosis of anything. So in that scenario, it's just a reaction to the inflammation and inflammatory process. Now, on the other hand, if you do not have atypia, it doesn't mean that you do not have cancer. These are two examples of lobular neoplasia and tubular carcinoma. Both of them, when you look at them, individual nuclear and cytological atypia is very minimal. However, the pattern upon which they are presenting and mono cell type, one cell type, no myoepithelial cell is really present in here. And that's how we make a diagnosis of these, low-grade breast cancers. And of course, that defines the fact that lack of atypia does not exclude malignancy. So let me give you a story. There's a patient who referred to a surgeon for a palpable breast mass. The surgeon ordered a mammogram and performed a fine needle aspiration biopsy. The findings of the mammogram were suggestive of fibroadenoma, and the diagnosis of fine needle aspiration biopsy was malignant. Well, when that happened and the patient underwent mastectomy, there was only fibroadenoma there. And when you look at it, this woman awarded about $2.7 million for mastectomy after this diagnosis. And unfortunately, this happened in Jacksonville. And this single case was enough that our fine needle aspiration biopsy clinic started to really become very, very empty, because no surgeon wanted to go through that process. And the reason that we have this kind of process is no attention was made to breast imaging, because if a young person comes and it is the diagnosis of imaging is fibroadenoma, you have to pay attention. And don't call a fibroadenoma that by the nature of what they are, they're cellular, as an indication of malignancy. No review of the cytology slides from outside medical center was performed, so they just assumed that the pathology was fine, and no communication between the surgeon, radiologist, and the pathologist occurred. These are the issues that we are dealing with. This has nothing to do really with the whole concept of, fine needle aspiration biopsy. We do not really do what we need to do to try to integrate the information, communicate with each other, and try to come up with a reasonable diagnosis. So there are unresolved issues surrounding fine needle, and this continues to stay there, and that is significant diversity of practice of fine needle, lack of recognition of limitation of fine needle aspiration biopsy, and lack of standard guidelines. This process naturally brought a lot of attention many years ago to the scientific cytopathology community. As a result of that, the workshop was planned at NCI, and there were a lot of really work done to try to really come up with some uniform guidelines how to practice fine needle aspiration biopsy, and that was widely published, and these are the areas that naturally they were providing some direction. In the area of diagnostic terminology, which I had the pleasure of chairing that session, we ultimately came with a strategy that we diagnose cases as benign, which have to undergo follow-up, atypical, indeterminate, that requires surgical excision, suspicious, indicates that it requires biopsy, malignant, can go straightforward to the treatment, and unsatisfactory, when we don't have enough cell, we have to repeat and resample the lesion. And when we look at diagnostic issues that occurs, and we are dealing with that, is in cytopathology, it is sometimes difficult to make the distinction in these entities. Atypical hyperplasia versus low-grade carcinoma, papillary lesions, papilloma versus papillary carcinoma, fibroepithelial lesions, fibroadenoma versus Floyd's tumor, sclerosing lesion, mucinous lesions, and the status of invasion. And when we look at the whole concept of how difficult they are, we can just go through, some of the examples of how do we make a diagnosis. Fortunately, the intermediate or atypical category in breast fine needle aspiration biopsy is really less than 5% of the cases. So they're not that frequent, and when we recognize them, all we need to do is just practically, ask for surgical excision. This is an example of atypical dactylar hyperplasia versus low-grade DCIS. And once again, when you look at it, the difference between these two entities is the presence of myoepithelial cells. You have heard from Dr. Shaheen, who really very beautifully talked about the significance of myoepithelial cells and how you would recognize them. We put a lot of emphasis in distinction between myoepithelial cells that are smaller, they're much darker, and they're spindle, and they're within the epithelial cells, not surrounding them, versus cases of carcinoma that you practically see one set of cells. There is that monoclonal proliferation of neoplastic epithelial cell which gives this recognition. And of course, when we look at atypical dactylar hyperplasia versus low-grade dactylar carcinoma, you all are aware of the complexity and challenges that exist, not only in fine needle, but core needle biopsy and surgical biopsy, and you're all aware of all of the studies that still continues to show the inter-observer variability that we observe in surgical pathology. And in many ways, I believe that this distinction is just like photography. For a good photography, not only you have to have a good photographer and good camera and a good light, you need to have a good subject. And I think atypical proliferative lesions of the breast and precursors of the breast lesions are not yet well defined, and we don't know what is it that you're talking about. And in that setting, it is very difficult to try to really put the blame on cytology or core and vice versa. This is just the nature of that. We don't have yet anything aside from our morphologic recognition of these entities to try to really help us by molecular technology or at the moment by immunocytochemistry to make this distinction a little easier. Let's talk about papillary lesions in cytopathology. You heard a very comprehensive lecture on that by Dr. Shaheen. In cytopathology, intradactyl papilloma or benign papillary lesions they are heterogeneous. When you look at the multiple examples of the epithelial cells, you have macrophages, you have epithelial cells, you have myoepithelial cells very nicely. And we, in our cell block preparation, we all the time use myoepithelial cell marker to try to see whether we are dealing with a benign lesion. And intraductal papillomas, they often present themselves with a very strong either P63 nuclear staining or with calponin as a myoepithelial cell fiber. And then in that setting, it is very easy to make that distinction. That is in contrast to papillary carcinoma. This is an example of a papillary carcinoma. As you can see, there are clusters of cells. It's very cellular. And then within that cellular component, all the cells are pretty much the same. And then you see some fibrovascular core there. Once again, cell block preparation, immunostain for myoepithelial cells that does not show any evidence of myoepithelial differentiation. So we will have no problem of calling it papillary carcinoma. Fibroepithelial lesion. Fibroadenoma is the most common lesion that can be diagnosed or sampled by fine needle aspiration biopsy. In the clinical or the classical form of that, as the name implies, you have the stromal component and then you have epithelial, myoepithelial component. And in contrast to fibrocystic change, the stromal component and epithelial component are two separate components. They're not intermingled together. And then, of course, the angular horn pattern that you see in the lower part of this will give you an indication to the fact that classical form of fibroadenoma in young individual is very easy to diagnose. The complexity that it comes, very similar to the case that I just showed you with medical legal issues. Fibroadenoma, occasionally they are associated with extensive proliferative changes in the epithelial component that make it very cellular, or they are very cellular with the presence of myoepithelial cells in the background that give the impression of a primary breast carcinoma. Once again, either in D-stained pap smears or in cell block preparation, myoepithelial cell marker can really help us to define the lesion as a benign entity. And this is very important to practice since myoepithelial cell markers are relatively inexpensive and easy to interpret. Of course, when patients are older, the lesions are larger than 4 centimeters, and you see myoepithelial, you see the stromal component and myoepithelial component is the fibroepithelial lesion. The stromal overgrowth is going to be the one that will lead you to think about Floyd's tumor. And of course, if you have atypical cells and mitosis associated with that, then you're going to be leading to call the lesion malignant Floyd's tumor. A sclerosing lesion is just a sclerosing adenoma, but the thing is that is occasionally give you the impression that they're just monotonous, there is no myoepithelial cells in here, and then you can see significant amount of sclerotic material there, and this is an example of a sclerotic lesion. Mucinous lesion, the typical example of colloid carcinoma occurs in older age group. They are unified and very ill-defined, very, very well-defined lesion. And of course, you can see mucin and epithelial component. Once again, if you do the myoepithelial cell marker in these, they don't show any myoepithelial cell differentiation. In contrast to mucocele in the lower part of this sclerochrome, which occurs in younger age group, you may have cytologically very, very similar features that mimic mucinous carcinoma, but the age of the patient, lack of myoepithelial cell differentiation, it differentiates that from mucocele that is often associated with other proliferative lesions in the breast. Therefore, that distinction has to happen. And again, if you have a signaling pattern that make you think about either lobular carcinoma or signaling carcinoma of the breast, always keep in mind that the patient may have metastasis from other sites. That's the lesion that, as you can see, you have signaling cells. Cell block shows great amount of mucin. And we happen to know that the patient had colloid carcinoma of the intestine a few years ago. So we subjected to electron microscopy examination. And then you can see the villi, which define that as a colloid carcinoma metastasis to the breast rather than a primary breast carcinoma. So once again, If fine needle aspiration biopsy is done in a way that you integrate all the information that you have and properly use the ancillary studies that you have, it really brings a lot of very interesting diagnostic situation that it would make your clinician to trust you. Because often when you call them and say, this is what it is, they say, how do you know that? Did you know that the patient has, colon cancer? And of course that will, bring a little bit more trust among the physicians. Another criticism to fine needle aspiration biopsy is inability to distinguish in situ from invasive cancer. That is a problem that exists and is very difficult. However, I had an opportunity to serve as a visiting professor at Curie Institute and have a very active breast fine needle aspiration biopsy service. So we have looked at the over 200 cases of fine needle aspiration biopsy with histologic follow-up and used about 10 cytologic criteria to see whether we can make the distinction on cytology alone, if you can make that distinction. And it appeared that evidence of a stromal invasion, as you can see, this is the adipose tissue that you can see all the clusters of tumor cells with it, presence of cribriform pattern, and necrosis are the morphological features that will help you to try at least suggest that possibility. And of course, other diagnostic clues are recognition of special subtypes of breast cancer, such as medullary, cystic papillary, and small cell carcinomas, presence of skin retraction, fixed nipple, ulceration, presence of inflammatory carcinoma, and evidence of metastatic disease. If you go and you see a patient that has palpable lesion, you always have to really examine the axilla. And if you see anything that is palpable, you need to also sample the axilla. So with one setting, you will diagnose cancer and you can stage the disease at the same time. And that's a significant, really, cost saving to the patient and to the medical community if we can do that simultaneously. Another area that there has been a lot of studies done in the literature is the ability of fine needle aspiration biopsy to predict response to therapy. Now, we can very easily, using cytologic material, to examine the tumor cells for presence or absence of estrogen progesterone receptors and HER2 or for that matter, any other new markers that comes in board. And this is an example. Actually, this slide is the first slide that we use immunocytochemistry in breast cytopathology, and as you can see that there are 20 slides almost that show that you can use cytopathology and cytologic material for hormone receptor assays. And of course, we can do similar thing in cell block preparation, and the nuclear staining naturally define the presence of hormone receptors. Similarly, these are the examples of use of fine needle aspiration biopsy for assessment of HER2 oncogene by immunocytochemistry in cell block, and we prefer to try to use the cells for HER2 oncogene because that gives us the ability to look at the nuclei a little bit more separately and they're not overlapping to each other. And you can see very easily, you can see the presence of gene amplification in HER2 oncogene by FISH technology. So when we look at all of the components that can be really accomplished, I see cytopathology is a reflection of surgical pathology. And often it's very interesting. People don't recognize me as a sort of a breast pathologist or surgical pathologist, and they keep talking to me that you're a cytopathologist, and I said that you have to be a good